الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه أجمعين. I would like to welcome you all in our webinar titled the Cervical Radiculopathy in the Young Population. It's a multidisciplinary management webinar. I'm very happy to moderate this session today on behalf of the Saudi Spine Association. We have with us today a wonderful group from pain management consultants to neurosurgeons, osteopaths, and physical therapists. And I think today, hopefully, we will leave you with a fruitful discussion, and hopefully we'll have a consensus at the end on how to approach these type of patients and the current epidemic of COVID-19. So we'll inshallah, we are expecting to finish at 11:15. We'll be presenting the cases in sequence. So I would like to first start with our colleague, Dr. Abdulkarim Al Rabie. He's a consultant neurosurgeon at Prince Sultan Military Medical City. He will present the case that we will discuss. So the sequence we'll have is Dr. Abdulkarim is going to have the case, and then we'll address it from different perspectives, and we'll give we'll leave the discussion at the end of each discipline. We'll open the floor for a few discussion, and then we'll have at the end of of our talks today a 15 minutes for for an open discussion for the whole speakers. So Dr. Abdulkarim, if you may start with the case, please.
Yeah, sure. Thank you, Othman. Assalamu alaikum, Ramadan Kareem. First of all, I'd like to thank the Saudi Spine Society for this great continuous organization for webinar meeting. So as Othman mentioned, tonight our theme is cervical radiculopathy management. I'm going to start my presentation by the case, and then we will discuss the treatment and management with my colleagues. So unfortunately, I tried to open my presentation, but it's not. Yeah. Yeah, there. Okay, so cervical radiculopathy. I have here all my presented of neck pain for more than 3 months, radiated to the right upper limb, and it's associated with on and off numbness. There is no history of trauma, no neurological symptoms. Examination where the power was 5/5 all over, and he had some decrease in bicep reflexes in the right side. Also, he had decrease in as usual, we did an X-ray, lateral view, and as you see here, there is a cervical degeneration, especially at the C5, C6. There is decreased height of disc, and there is some osteophyte, some sort also of foraminal stenosis. MRI also, it showed that there is disc herniation at the level of C5, C6. with cord indentation, and if you can see the axial view also, there is bilateral foraminal stenosis. The right side is more than the left side. So at this time, I start to treat the patient by starting him in painkiller, and I sent him to a physiotherapy clinic to start the management for conservative. And 3 weeks later, he back to my clinic. His pain, right upper limb pain, is still there.
We lost the voice.
I think we've lost you, Dr. Abdulkarim. Dr. Abdulkarim, can you hear us?
And we'll see.
Dr.
Yeah.
Dr. Abdulkarim. طيب. Maybe the connection at the end of Dr. Abdulkarim is not the best. So Bilal, can you stop the sharing of his slides? Is that possible? Okay. So clearly we saw the images and the case, and I think,
sorry.
Dr. Abdulkarim, we've lost you. I think the connection is not stable at the end.
Is it good?
Not the best.
I'll try my best. So I at this point we'll stop here, and then I send the patient, you know.
If you allow me to interrupt you, Doctor, the line is choppy. So we'll move to the next person who's going to speak with us, Professor Jorge Esteves. He's a consultant at my osteopathy clinic in Riyadh, KSA. He's an honorary professor at the University College of Osteopathy in UK, and a visiting professors in University of Julio, I think. How do you pronounce it?
Camilo Jose Sela.
My Spanish is bad. And Spain, and also he's a vice president of COMT Collaboration Research Group in Italy. We'd like to welcome you with us today.
Thank you very much.
And we would love to see, you've seen the case and we've discussed the case offline. Mm-hmm. So we'd like you to start, giving us your, how would you assess and treat the case from your perspective?
Sure. So let's share this. Okay, so see if this works. So we know we've got the first introduction to the case. I will focus just on a few key elements here. So let's imagine of course, I'm seeing the patient. I don't know the final outcome. Actually, was that he needed to have surgery. So we've got a patient with radiculopathy and a disc prolapse at C5, 6. And pain and numbness, etc. So he's also on medication, so he's taking pain medication in Lyrica at the moment. So first of all, I think it's important for those of you that are not entirely familiar with osteopathy to understand a little bit about where we come from. So here, I'm not just interested in the symptoms of the patient. I'm not just interested in actually what's going on with his cervical spine, with his spine, with his radiculopathy, but try to understand the individual. So try to focus primarily on a kind of from a person-centered perspective. Try to understand that patient and what's going on. So a few concepts that just sort of put this into perspective. So of course, we can look at the sort of neuromusculoskeletal structures that are clearly important in this case, and in the relationship between different parts of the body. So, for example, in the case of the cervical spine, relationship with upper extremity, with thoracic spine, with the head itself. So, and other, including also visceral structures, etc. So, thinking about relationships between normal and abnormal tissues. So we know he's 40 and he's got some, from the X-ray, some degenerative changes. We also know from the evidence that actually that is quite prevalent in asymptomatic individuals. So, something to take into perspective. But apart from the kind of biomechanical and, structural aspect of the case, I'm also interested here in cognitions, emotions, and in particular with this case, apart from relationship between different parts of cervical spine and the relationship, for example, with cervical thoracic dynamics, thoracic outlet, etc. Try to understand a little bit about, for example, any history of previous accidents, for example, any trauma that may be a predisposing factor to this case, relationship with cervical viscera. But also, in particular, in the context that we're living at the moment, for example, concepts of allostatic load, so work, finances, home confinement, so the whole stress and what that can do actually as be one of the important aspects of the multidimensional nature of pain. And with that, we can think about any kind of maladaptive patterns, can either be fascial, musculoskeletal, but also from a sort of a neurological perspective in terms of, central sensitization, for example, emotions, all of that playing a role. So, clearly I'm interested in the individual, as I said when I started. So purely mechanically and, from a structural perspective, I can look at the cervical spine and think about, the different aspects of the parts of the cervical spine and, their function, and try to understand why, for example, there is a certain increased load at the mid-cervical spine at C5, 6, what may have contributed to the onset of the case. But also to try to understand that actually pain is not a sensation and, it's largely a kind of a, it's an action problem. And, a lot of this is about sort of protective mechanisms that actually happen in that individual's sort of central nervous system, what the brain is actually doing to protect the individual, which might play, an extremely important role in the onset of the problem. So there's many lenses as osteopaths, people talk about different models of care. If we put it together into simple kind of dimensions, traditionally lots of osteopaths would look primarily from a biomechanical perspective. And more recently, people started sort of moving more towards a biopsychosocial dimension, which is not unique, to osteopathy, as we know, but it's important to take into account in this particular case. So how do I navigate through the case? Imagine the patient comes through the door. So try to understand the patient's story. So I'm, not just interested in the symptoms, what happened, what started the pain, etc. But try to understand really the whole story of that individual. And we know that at the moment, the patient is particularly worried about what's going on. So clearly any red flags, anything that requires emergency referral, but start thinking about also the sort of yellow flags, blue flags, orange flags, for example, any sort of signs of depression or anxiety, for example, any kind of necessary differential diagnosis, and then start thinking about, once we've gone through that sort of initial kind of stage and thinking actually it is safe to consider this patient, to kind of treat this patient, start thinking about the concept of a bigger picture, which, it's not just the interrelationship between parts of the body, but also, those sort of cognitive emotional elements, the stress, the allostatic load, and then the little picture, which is, clearly where is the pain coming from, what sort of tissues are involved. So, in particular with this case, any kind of clear neurological deficit, what can I do? And try to sort of, develop a good therapeutic alliance with that patient, moving into the kind of reassurance that in this case, there were no clear signs of deficit and the intervention was something that could be done. And then start, the form, the osteopathic care. From a biopsychosocial perspective here, and a lot of people would sort of, argue that there's, not enough bio in the biopsychosocial model. depends clearly on each individual. I don't know much about the story of this individual, but clearly it could be that in this case, that's much more the biological side of things, and then less to worry about the other stuff. But, we can sort of also look, change a little bit the lens depending on what the patient presents with. So try to understand that patient. And in terms of what we would do and the kind of immediate short term, clearly try to kind of, important aspect at the beginning would be to, go for symptom modification, try to interrupt any kind of negative beliefs. And treatment is not about changing tissues, but it's very much about sort of try to give the patient some comfort, try to give the patient some kind of, advice that they can, they can start managing the case. Assuming that things are started improving and, we can start thinking about more kind of restoration of the capacity, try to kind of create some changes. And at the same time, try to start increasing capacity, thinking about multimodal interventions, for example, exercise and kind of the role of the multidisciplinary team. In terms of long term, again, depending how the patient, improves or not, we could think about more this concept of restoration of agency. So just to finish, a few important points to take into account here. The kind of important to sort of identify the contributors to this perception of danger, the thoughts, the behaviors, the beliefs, the sort of protective stuff, but also the sense of safety. What sort of things would actually enable the patient not to sort of move into a chronic kind of condition. So try to understand and recognize their emotions, educate all the time, because that will help kind of, enable them to make some sense of their pain. And the osteopathic techniques here, it's not necessarily about correcting dysfunctions per se, but, we can think about more as a sort of a way of desensitize that nervous system, try to produce some kind of neurophysiological, some, psychological effects, and progressively try to increase capacity to adapt, and then reevaluate all the time. So we could be in a situation that actually the patient does not improve in the way we want, and then we need to get in touch with, for example, consider the surgical route. So that would be my kind of osteopathic approach with the patient with cervical radiculopathy.
Excellent. So we might leave some discussion at the end, so we can receive 1 or 2 questions about this part. If anybody has any questions here before type. Question is, would you consider osteopathic manipulation for this patient, Professor George?
Yeah, so we would need to think about the sort of risks, benefits, and any kind of, any contraindications to the treatments, to cervical manipulation. It might, I would, if everything is safe, would definitely work on a thoracic spine to start. So, don't necessarily need to go straight into C5 and try to manipulate that. So if you think about the kind of try to improve function and, for example, offloading a little bit that part, I might think about working lower down. I might start, I might consider other techniques, not necessarily high velocity thrust, but for example, muscle energy techniques or ways of sort of, improving a little bit of the quality of movement elsewhere. And so that's how I would approach that.
Excellent. So any other questions? Okay, so another question says, what is the first intervention you will start with in this case? So I know that you mentioned it, but you can briefly highlight. I think you mentioned some education and working in an indirect way.
Sure. So on the first appointment, one important thing would be to start educating the patient about the nature of their problem. So one strategy I use that's kind of developed by Greg Lehman is using the metaphor of the overflowing cup. Try to get the patient to understand that the pain is multidimensional, and although there may be in this case clear kind of physical aspects, there's a lot of other stuff in the cup. And if you're thinking about COVID-19 and the stress and everything, you're not sure about, his future, the income, etc. So, try to sort of think about, okay, what is in the cup? So that would be an important aspect. A lot of reassurance on the first appointment. If there's nothing serious, try to pass that message to the patient. And in terms of the osteopathic intervention at the beginning, I would probably, again, imagine the patient is super stressed, high allostatic load, probably do some, techniques that actually, in a sense, help modulating a little bit autonomic nervous system function. I would probably work also on neuromobilizations, just sort of start getting some, desensitizing a little bit those, even peripheral structures.
All right, so, okay, it seems that there is lots of hot questions for you. We'll leave it to the end. And if you can tap on the Q&A,
sure.
And you can answer them by text. And then we'll leave some of the questions to the end. It seems that you're receiving some good questions here. And we'll I'm cautious about the time. We'll leave the floor now for, thank you, Professor George. We'll leave the floor now for the next speaker. Next speaker will be Abdullah AlMuhaya. He's a senior spine physical therapist at Physiotrio Clinic. He will speak about the physical therapy approach. And I think the topic Abdullah is going to talk about is, are we following the right treatment? Abdullah, the floor is yours.
السلام عليكم. واضحة الشيرنج سكرين صح؟
ايه واضح.
Okay. So today inshallah we're going to talk about for cervical radiculopathy, but I'm going to talk for sure about following the right path in physiotherapy point of view. So at the beginning, as a physiotherapy, we divided for neck pain patient, we divided them into 4 grades. And grade number 3, we focus more on neck pain without sign or symptoms, but with neurological sign and symptoms, patients such as cervical radiculopathy. So if we have a patient with a history of sensory symptoms in the arm, paresthesia, numbness, or reduced sense of touch, also restricted of cervical rotation, especially if it's less than 60 degrees, reduced muscle strength or muscle control, and radiation pain in the arm. From that history, we will include this patient for grade 3 symptoms, which is with neurological symptoms. Through that, we can analyze that patient through 4 profiles. And the profile number D called a neck pain grade 3, which is neurological sign and symptoms. And these patients, we can take them under consideration of a special approach of a treatment comparing with other neck pain patients. So for profile D, neck pain grade 3, we can treat this patient upon their goals, but in general, the goals is influence prognostic factors and management according to clear time path. And this is important thing to teach the patient what is the time path that we are working on, and when that we refer back to the GP or to the doctor if there is no improvement. And for the education and facilitation active coping, exercise treatment upon needs and goal of the patient. Then we will do cervical and or thoracic mobilization and manipulation upon patient preference actually. Work related, we contact the BT specialist or the OT specialist who's actually has specialized in work environmental change, but we will not do a changing in the environmental until the patient have a pain. But if there is no pain, we'll not try to change the environment in general. terminate the treatment if there is no improvement after 4 to 6 weeks in general. We have a lot of optional therapy such as cervical cushion, cognitive behavior therapy, kinesiotherapy if it's up to trauma, massage or heat therapy, workplace intervention as I mentioned, and cervical and thoracic mobilization with a combination of neurodynamic mobilization exercise. Also soft neck collar, and I'll talk about it. It's for like a period of 2 weeks at the beginning, and we re-evaluate the patient after that, and then traction. But the ultimate treatment is exercise treatment from a physiotherapy point of view, and cervical thoracic mobilization manipulation. For explaining the diagnosis to the patient, to reassure the patient that the sign and symptom will disappear or stop by itself. And also physical activity, lifestyle, active coping style will be advised. However, also recommend the patient to avoid movement or activity that might provocate the pain or provocate the symptom that radiating to the arm. And we need to focus also on the treatment that's not recommended, especially for the physio. We have a lot of modalities, and there is some modality are not recommended for such cases, such as dry needle, electrotherapy, ultrasound, and laser. We are talking about not recommended for radiculopathy, but however, you can try it if there is no harm for the patient and you see some benefit from that. Before you start your assessment, it will be a good assessment to start with some outcome measures such as neck disability index and also patient specific function scale upon the recommendation. For the screening, you need to focus on the range of motion on cervical and also on the thoracic. And then you need to do active screening for the radial, ulnar, and median nerve as a screening test. If the patient reported some radiating similar to their pain, we will try to do some palpation on the point that usually it's a common point for the nerves, even for the ulnar, axillary, median, which nerve that patient will complain of, and the movement will be similar to that nerve. Then after that, commonly, still it's a weak clinical value, but commonly we do that as a peripheral nerve, peripheral upper nerve test, which is either we do a myotome, dermatome, and also reflexes. After that, now you are in that spot of cervical radiculopathy. So we recommend to do cluster of Weiner, which is you do 4 tests, either perform upper limb tension test. Then after that, you perform evaluation of cervical rotation. And we say that if it's painful, less than 60 degrees, this will be a positive sign. Perform traction, which is the pain will disappear, and spring test. 3 or 4 or 4 or 4 will consider as a moderate value or clinical value to confirm radicular syndrome. Now, when we confirm this test, you can see here, this is the upper limb tension test. And then you will do the traction test. The patient will report the disappear pain. Then you will do spring test. And here I put two tests that at the beginning with the acute case, it will be hard to perform the compression immediately. So I would recommend that you go away from the complaining side and do the spring test. If the patient complains of the similar pain, you can go gently do the compression itself. There is some 3 signs more. It's a weak clinical value, but also it will give you some idea about the radiculopathy, which is the shoulder abduction sign, and also valvular maneuver and squeeze test. This will give you similar pain to the patients that will confirm your assessment. Now, if you confirm that, you need to know that there is no operative, non-operative treatment. A lot of treatment such as strengthening, such as NSAIDs, such as muscle relaxing, massage. But however, no treatment superior to the other treatment, and no treatment have a high quality studies to be better than the other treatment. In a patient with red flag, or the patient who will have resistance pain or symptoms after 4 to 6 weeks, this will be considered to refer back to the doctor, and they might refer them to do an MRI, and the epidural steroid injection or surgery will be the ultimate treatment for them. Weakness is reported by 15% of the patients, so it will be okay that if you have a patient with the weakness, that not considered as a red flag for your patient. Improvement will be from 4 to 6 months, and fully recovery will be 24 to 36 months. However, will be full recovery in the majority of cases if there is no myelopathy at all. For the therapeutic exercise, we recommend a lot of patients have some pain. So with depends on the goal and the needs, we'll have some exercise. Either you'll work on the cervical, you'll work on the thoracic, you'll work on mobility of the thoracic, mobility of the cervical, you work on the neurodynamic mobilization, and also you will work with a strengthening of the shoulder. You'll increase it also with scapular strengthening. For other treatment of the physiotherapy, there is low quality evidence support for the traction, and however, it's concluded that it's no better than placebo reducing the pain. For the soft collar, as I mentioned, there is a little improvement regarding comparing with the semi-hard collar, but in general, the first 2 weeks we'll consider wearing the soft collar, especially with driving the car or while sleeping. For the massage or strain, counter strain, traditional Chinese massage, will have a low quality evidence. However, there is more than 15 trials with the study. So as long as there is no harm, you might do it. But as I mentioned, the ultimate treatment is exercise. There is some question about the pillow. So there is one study talking about the functional cervical pillow, which might consider not a treatment, actually more than a complementary treatment. So if the patient has a discomfort or functional pain, maybe the patient will have some special pillow upon their need. At the end, the physio will have more in a manual therapy. So the manual therapy actually has no high quality studies. However, that manual therapy combined with exercise treatment is actually associated with a positive outcome in patient with cervical radiculopathy. Either you can do mobilization with the cervical, you can do some mobilization with the neurodynamic, mulligan with snag with arm movement, or sustained snag. We can do manipulation of the cervical, manipulation of the thoracic. You can do also a mobilization with the first rib, and also you can do some stretching with the scalene or levator scapula. If you go to the sleep position, there is no evidence support in a sleep position superior to the other position yet. However, with the acute case, we recommend that they wear a soft collar, and also they can move in the bed when you move from lie to sit, such as a robot movement. Some pillow we recommend to have this, some pillow, so the arm that affecting the arm, such as our case will affect in the right arm, they will recommend that raise the arm, shoulder up, so the patient will have reduced the symptoms. So this pillow will help also the patients. At the end, some of the patients will prefer to have this sleeping position, so the arm will be in the rest position, then the pain will be less. So with the prognostic, regardless of the treatment modality, so most of the patient will improve. However, most of the patient, 80% of the patient will improve within 4 weeks. 80% of this object, they will have weakness, or they will have deficit, some deficit improve within 3 weeks of starting the treatment, not starting the pain. The optimal time of referral back to the doctor, there's no actually clear time. However, evaluation treatment will be done after your treatment using some outcome measure. And if the goal achieved, the treatment should be stopped. But if there is no improvement within 6 weeks, I would recommend to refer back to the doctor. However, if your treatment insufficient or have led to deterioration of the case, I would recommend also to take the patient, refer back to the GP or the orthopedic doctor. There is some evidence to support referral with 4 to 8 weeks, but as I mentioned, that's not clear in a time to refer us upon to the therapist. As a take-home message, I will have like 5 points. Active rest, will be recommended to the patient, not a passive rest. Postural motion and re-education upon the patient goals. Advise a physical active lifestyle and an active coping style depends on the goal also. Exercise, 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 even if it's mild mobilization of the neck, mobilization of the thoracic, this is all considered as exercise. As at the end, it will be okay to refer back to the GP if there is no change within 4 to 6 weeks. However, if you have some moderate change, you can continue up to 3 months. This is will consider as a normal improvement of radiculopathy. The last slide here, I have an algorithm of management of cervical radiculopathy syndrome. It will be nice that you have it in your clinic. If you don't memorize the sequence with the experience, you'll have it. So it will be nice that you follow it step by step and you see where are you working on, and you can see if you are in the right path or not. Thank you so much.
Excellent. Thank you, Abdullah. I think we'll leave the questions for Abdullah in the Q&A box. So Abdullah, you may answer them on the box in the bottom by text, and we'll keep the questions to the end.
Sure. Can you stop my sharing? So
yeah. Right.
Okay,
so,
thank you.
Right. So our we're trying to go on sequence. So for those who joined us late, we had the case. The case was presented by Dr. Abdulkarim, who's a neurosurgeon with us today. Then the case was started the conservative treatment with Professor George, who is an osteopath. Then we talked about the physical therapy perspective of the case. And now we're assuming if the patient is not improving well and still we have pain as a challenge, and the patient will go to see a pain consultant. Our pain consultant we have today is Dr. Osama Alahdal, who is the chairman of the Department of Pain Medicine in the International Medical Center in Jeddah. Dr. Osama, we're happy to have you with us today, and we would like you to shed light. What if the patient is still struggling through pain, and we would like to consult a pain consultant to see whether or not you can help in that dimension?
Thank you very much, Othman. I think you can hear me very well here, is that right?
Yes.
Good. So many thanks to Saudi Spine Society for their invitation. I'm gonna share my slides here. Okay, hope it is there. Okay. All right. Can you see the slides, all right?
Yes, we can.
So basically, this is a case of a young patient who had a C5-6 disc disease with radiculopathy, and the sequence of events in the treatment should be started with simple medical therapy, osteopathic, physical therapy, and then pain management, and then surgical intervention. And this is the common sequence we use in the management of these cases. Just to start with, the prevalence of neck pain and shoulder pain is in the rise. And I just quote this article, which is published in the last year from King's Saudi University by Rawaf, and he did a prevalence study on about 5 or 6 high school students in Riyadh area, and he collected over 560 cases, and he found out that the prevalence of neck and shoulder pain in the young age group is really high. It's just you could see that it's almost 50% in all of them, basically, out of the samples that he collected. So, and of course, those you would expect at least 5% might go into the chronic stage in the future. So the neck and shoulder pain or neck and radiculopathy as a complaint will be on the rise in the coming future. What we looking for when in pain management is the pain generator. Where is the pain coming from? And as you know that the spine in the cervical area is really a complex structure, like all the spines, but it's in particular in the cervical spine because of the presence of vital structures such as spinal cord. In addition, that there is the vertebral artery, which complicate the exiting nerve root treatment. But the generator of pain is basically, we look at the disc as a pain generator, and specifically the posterior annulus of the disc, where there is a lot of nerve endings in the second generator will be the posterior longitudinal ligament. Third generator will be the material that comes out of the nucleus bulbosus, which contain very high concentration of phospholipase A, which is a pro-inflammatory, and then it will really burn the nerve root when it comes out. Other generators is the bony osteophytes and the facet joints, as well as facet arthropathy, and hypertrophy of the ligamentum flavum. So these are a pain generator that actually can produce pain in addition to the neurologic symptoms that occurs from pressure on the exiting nerve root and or the spinal cord itself, depending on the disc disease or where is the pathology. So what are the common procedures we do in the in pain management? And by far the commonest procedure we do is a cervical interlaminar epidural steroid injection. The second one will be the transforaminal epidural steroid injection, although transforaminal epidural steroids is dropped out of favor with a lot of pain physicians because of the high risk of complications with the transforaminal approach, and more safer is the interlaminar approach. So this is the commonest technique we use for treatment of pain in cervical radiculopathy. And the second one we use is basically cervical medial branch block, which is the nerve that supply the facet joints coming out of the posterior rami, and it supply the facet joints. We do first block technique under ultrasound guidance, and then we, if the patient is positive and pain is relieved, because the block is temporary, we go into the radiofrequency ablation of these nerves under fluoroscopic guidance. We can also help the patient by doing what we call nerve root block, commonly under ultrasound guidance. And the nerve root block is basically to help the surgeon to locate the level of the pain and the level that he can work on if the patient has a multiple disc level, specifically in the MRI finding. So by doing a selective nerve root block, actually will help to determine the level where the maximum pain coming from. Other technique we can use is a neuromodulation procedure, where an insertion of spinal cord stimulator, which can be either by the neurosurgeon or percutaneously by pain physician. We can do also DRG stimulation, which is now becoming of increasing use. And instead of going into the dorsal column stimulation, we go to the periphery and the stimulation directed to the dorsal root instead of the dorsal column. Another procedure we can use is the intradiscal radiofrequency, or we call bicalplasty, where we introduce the radiofrequency needle into the disc itself, and by having a radiofrequency in the disc, we can actually ablate the nerve ending in the posterior disc annulus, and that help in reducing the pain of the patient with a good evidence to to suggest that it's really a good treatment for specifically for having a wide central disc herniation in these patients. There are also few coming report of the intradiscal infiltration of the plasma, platelet-rich plasma, or what call it a growth factor release. And it is an increasingly used. It takes only the blood from the patient, centrifuged, and a concentrate of platelet-rich plasma can be injected into the disc itself, intradiscal. So as we have a short time here, we can just gonna go through quickly to the interlaminar epidural injection, which is a commonest technique we use for cervical radiculopathy. These cervical epidural injection is indicated mainly for cervical radicular pain, which has the highest results, positive results. Also can be indicated in patients with discogenic or cervical discogenic pain, which is different from radicular pain. We can use it for patients who had multiple facet arthropathy, where mainly the patient complained of neck pain without radicular symptoms. And we use it also for post-laminectomy pain syndromes. But there are also other uncommon indications like post-herpetic neuralgia, post-traumatic neuralgia, muscle contraction headaches in these patients, spondylosis, pain from malignancy, and a patient with reflex sympathetic dystrophy. So these we can use a cervical epidural injection to treat their pain as well. If we look at the evidence, it is actually variable. The original recommendation, which is this is a study published in 2019 in pain practice, but actually this is a work done by a Netherlands group where they looked at all the evidence for most of the cervical injections and radiofrequency ablations. 2010, the interlaminar epidural steroid has an evidence of 2B, where a lot of people are actually giving it. And later on in 2015, it shows it's a moderate evidence that this procedure will work on cervical radiculopathy. And recently in 2018, they state that it is actually a weak evidence. They stated the weak evidence because of the number of the studies are really not enough to reach a good conclusion out of them. But this is also opposed by another meta-analysis done by a group from Utah in USA, and they have also looked at all the literature and the effectiveness of fluoroscopically guided cervical transforaminal epidural steroid injection. And they have concluded that 50% of patients experience 50% of pain relief, both at the early and intermediate term follow-up. They stated that, again, the quality of the papers are really low to have a better conclusion, which goes with our own experience in the kingdom, that approximately 50% of patients that we do actually respond to have a good pain control. Our follow-up up to 2 years, and we have similar results in our center. Basically, how it is done is it's so simple. We have it 100% has to be done under fluoroscopic guidance, under sterile field. The patient has to be in a prone position. The common entrance is basically either C7-T1 or T1-T2 interval. In this case, for instance, is a T1-T2. And once we reach the epidural space, we have to inject a dye to indicate, to show that we are 100% in the epidural space, and you could see that the fat layers of the epidural space is visible there. And then we can do a contralateral oblique view also to indicate that we are 100% in the right position. And then we can introduce a catheter so that the catheter will aid in the spread of the injectate into the epidural space. And once we inject our local anesthetic or saline, we kind of have a look to the spread, whether both in the contralateral oblique and the lateral view. And you could see here the spread is going up into the cervical spine. And in the lateral view, you could see that initially it reached to the fifth cervical spine, and then with a higher volume of injectate, it can reach up to C3 or C2, both in the posterior epidural space as well as in the anterior epidural space. So basically, for the current case that we have, as we said before, we have to start all the patients with generally conservative medical therapy, then physical and osteopathic therapy, and then interventional pain procedure. And for this particular case, probably I would do only a single injection of epidural steroid. If not improved, then we have to go for surgical treatment. The thing to stress is that interventions in our modality is not to treat the neurologic symptom, it's mainly to treat the pain of the patient only. So if the patient is not complaining of pain, it's only neurologic symptoms, I think they should go into the physical therapy, osteopathic therapy, or mainly surgical intervention. But if the patient is complaining of pain, whether before the surgical intervention or even after surgical intervention, then pain management has a role in these patients. And with that, I would like to thank you. I'm ready for any questions or comments.
Thank you very much, Doctor. I think just for the time's sake, we'll keep. Please keep the question going on the icon of the Q&A, and Dr. Osama will respond to you by text there. And if we have some time, we will open the floor for some audio or some verbal questions. We'll move now back to Dr. AbdulKarim. I hope that now the network is better at your end, Dr. AbdulKarim. And we'll see now if the patient has gone through seeing you in the beginning, went to an osteopath, went to a physical therapist, no improvement, went back to the pain clinic, and he was from the 50% people who did not respond well, and then came back to you. What would be your line of action for such a case? The floor is yours.
Okay. Okay, sure. Thank you, Othman, and sorry for what happened regarding the internet issues. So back to this case, as I told you before, patients have that radicular pain, send him to physiotherapy and pain clinic as well. He received an injection, and he got back to my clinic with the same pain. There is no improvement. So 4 months later, the pain started to affect his life. It's affecting his job. So I decided at that time to go for surgical intervention, and I did ACDF and patient discharged next day. I saw him in the clinic 3 weeks later, and his pain is improved totally. So now of the cervical radiculopathy. So in general, the cervical radiculopathy in young adults is not that much common when you compare it to the elderly patients. And Liz found that the 45% of patients had only a single episode of pain. So that's meaning this pain can be treated conservatively. Unfortunately, there's 25% of patients had persistent or worsening of the symptoms, And also some patients have severe or progressive neurological deficit. At that time, surgical intervention is indicated. So I'll go through the surgical options we have it, and then we'll compare which one is the best to treat this type of disorder. So we have to go either anterior or posterior. And if we will think about the pathology of the cervical radiculopathy, it's either come from the disc, as Dr. Osama mentioned, or come from the facet, hypertrophy, or bone spurs. So try your best to identify what is the pathology. Make sure that the pathology, that's the size of the pain, and then go ahead to treat it surgically. So we have either, as I mentioned, to go posterior or anterior. Posterior, we have the cervical foraminectomy, can be done either by open or minimally invasive. This procedure was introduced by Sterling at 1940. And the good benefit from this procedure is direct visualization to the nerve. So you can see the nerve and you can release it. You can take the disc, if it's a soft disc there, and it can be done as day procedure. Patient can be discharged the same day. So regarding the technique, it's a simple technique. It's 2 centimeter lateral to the midline. Do an incision, use a tube for the minimal invasive. Once you see the lateral part of the lamina and medial part of the facet, start to drill it and identify the ligamentum flavum. Take the ligamentum flavum out, and you can see the nerve root and the axilla of the nerve root. You can go there and release it and take the soft disc, as I mentioned. We have to be careful here to not take more than 50% of the facet, because the evidence showed that if you take more than 50%, patient will have severe neck pain and he will have instability at the same time. Regarding the second approach, we have it is anterior cervical discectomy and diffusion. And I can say that the most widely used surgical procedure for cervical radiculopathy and myelopathy as well. So this procedure was introduced by Smith and Robinson at 1958. And the good thing with this type of procedure is you can just go direct, take the disc, and take the compression from the nerve roots without any mobilization or any retraction over the spinal cord. The outcome from the clinical outcome from this procedure is highly effective, and most of the patients, they are happy after the procedure. If we discuss that to do this technique with plating or without plating, the plating was introduced recently in 1990, and this evidence showed that there is no big difference between if you're gonna put plate or not, but there is some study showed there is a high risk of dysphagia when you're gonna put a plate. Although there is some studies show that you will save the alignment and also to prevent the future kyphosis when you put the plating. So procedure, it's a simple procedure. You can go from the right or left, 3 centimeter incision in the skin, and the only muscle we will cut it is just only the platysma. The other muscle, we will dissect it, we'll go through the muscles, we will identify the disc, and then we'll take the disc out, and then we have to make sure that we decompress the nerve root by taking the ligamentum flavum, check the nerve flow by the hook, and also check the other side, because sometimes when you remove the disc, there is some small piece we can go there and compress the other side. And then you can put the graft, either it's bone graft or cages or whatever. The third options of surgical intervention is cervical disc arthroplasty. This one is one of the good procedure, and now I think it will have the big future in the future, as the benefit of the theoretical benefit of this options is to maintain the motion of the disease level, and it will help to decrease the adjacent segment as compared to the fusion. We will see at the end of the lecture which one is better than the other. Regarding the anterior cervical, the fourth option, which is anterior cervical foraminectomy, it's less likely to be done at this time because the high risk of vertebral artery injection, vertebral artery injury, as you have to go to the oncovertebral joint, take it off, expose the nerve there, which is at the side of the vertebral artery. So when we come to compare this type of procedure, which one is better than the other, or what's the best management to the patient? If we're going to compare what is regarding the anterior, either anterior or posterior approach, there is no evidence say that the posterior or anterior approach say one is better than the other one. Just only found simple studies there, and the evidence, these two study was published in 1990, and it showed there is no difference between if you will go either anterior or posterior. Although I believe that it depends on the pathology. If the pathology is anterior, go anterior and take it off. If it's posterior, go posterior and take it off. And if we will think regarding the minimal invasive posterior cervical foraminotomy, now I think it's a good procedure to decompress the nerve root and to take the compression from the posterior if it's there. If we will come to compare the ACDF, the fusion to the cervical disc arthroplasty, it's a controversy. There is no clear evidence say that one is superior to the other. And if I'm going to ask Google about that, he gave me 8,350 results, 50 articles about this comparison between these two procedures. So till this time, there is no clear evidence, as I said, make one better than the other. This study was published last year in 2019, and they compare the disc replacement to the fusion, and they saw the outcome over the 5 years. And they found that there is no important difference in the outcome after 5 years between the two procedures. This meta-analysis of randomized control trial also was published in 2018, and they compared the old technique, which is posterior cervical foraminotomy, and also the anterior, either fusion or without fusion by disc arthroplasty, and found that all techniques are effective to treat the cervical radicular pain and radicular symptoms. Although they found that the minimal invasive foraminotomy is lowest rate of complications, and it's as simple as to be done in a day case, and patient can be discharged at the same time. So, and they found that the disc replacement is lowest rate for the secondary operation due to the decreased risk of adjacent disc disease. So when we come to the adjacent disc disease or the adjacent segment disease, this study, it's a meta-analysis of prospective randomized control trial, and it's published in 2016. They review 14 RCT, and they found that the cervical the disc replacement is superior to fusion regarding of the adjacent segment disease as well as the reoperation. So when we will come to the conclusion, I think we'll start that the disease in general will not consider it as surgical from the beginning. We have to give the patient all of the options regarding the conservative, and we know that most of the cases it's going to be self-limited and managed conservatively. We believe now that the multidisciplinary approach to treatment of this type of disorder, it's the best option to use the medications, to use the pain injections, and physical therapy as well as osteopathy. Regarding the surgery, I think it's considered and indicated if there is no improvement in pain, and if the pain starts to affect the patient's life and affecting his job. So I think that's the time to do the surgical intervention. And as I mentioned, there is the old technique. We have it for the surgical intervention is still valid, and we can use it, and it's a good option, but it's based on the patient pathology and the surgeon preference. And thank you.
Thank you very much, Dr. AbdulKarim. So seems that so far we have around 800 participants. This is extremely good. We're very happy that this is very popular webinar. So if you would allow us now to have, we have 7 minutes more, and if you are okay with that, we can extend for another 5 more minutes to answer some of the questions. I would love if we can see, Bilal, can we accept some voice participation of the participants?
Yes, Dr. Sure, but no one has raised the hand until now.
Right. So if you can raise the hand in order for us to see if you have any questions. Right. So Ibrahim Kamoun, I think he has a question. Bilal, if you can.
Can you please unmute your mic?
Ibrahim, go ahead, Ibrahim.
Yes, it's activated, I think.
Yes, we can hear you. Okay. Can we go to Dr. Ibrahim Harani?
Thank you for this presentation.
Okay. Go ahead, Ibrahim.
مناش تسمعوا فيا؟
نسمعك تفضل.
Thank you for this presentation. I have a question about postoperative neck pain. What about postoperative neck pain? Because it's very common problem, and many patients are not satisfied by surgery because of this postoperative neck pain. They have no radiculopathy. The problem of radiculopathy is resolved, but the problem of neck pain is persistent. So my question about this postoperative neck pain.
Clear. Thank you. So we'll let Dr. ABdulkarim to start for briefly, then we'll have an answer from.
Sure. So that's I agree with you that some of patients will still have neck pain, and we have to make sure that the source of pain is maybe from the other level, because the degenerative changes once it's there, so the facet can be affected, and this could be arthritis. So we recommend usually to refer patients to physiotherapy. I think physiotherapy is the best option in this way to be done, as well as to take some pain medication to relieve this pain.
Okay. Anyone from the speaker would like to add? Abdullah, maybe?
I can corroborate Dr. ABdulkarim. I think some of the patients also, the expectation after the surgery is a big factor. So the patient will expect that after the surgery, the numbness and the pain in the arm will resolve immediately, and this is the big factor as a psychological, I think. So if the timeline of recovery before the surgery will be a huge impact in the patients to have a big orientation about what's the expectation after the surgery. That's one. When we talked before, I said it's good idea that the patient know what they will expect of the surgery, because some of the cases like the sport case, ACL and meniscus, they know the time frame immediately, like after 6 months, this is what will happen. But with the neck problems in general, it's hard to expect something. But if we give a time frame, I don't know, but this is a good idea or not. But if we give a time frame, I think it will be better outcome for the patient after the surgery.
I just add one thing. I think one important thing also to take into account is that some patients actually develop a fear of movement, and will sort of will limit themselves a lot to the sort of activities they do. So they lose a lot of their sort of self-efficacy and become less resilient. So I think, one important thing is also to get them through, you know, graded exposure through exercise, movement, and so on. So, you know, we can sort of build the confidence. You know, we can't, I don't think we can just simply say, think about, you know, the nociception of pain and take it that way, but, you know, go a little bit, you know, beyond that.
Excellent.
Thank you very much. I just want to add also a comment that the pain after surgery can be really acute or subacute and chronic. Acute pain is predicted by a patient who has previous chronic pain or the patient who were not treated well during the surgery, like the positioning of the neck, or giving acute good pain treatment intra-op as well as immediately post-op. Some of these patients might have a chronic pain where the multi-level pathology could be an issue, as well as the adhesions around the nerve root that could be another issue. And as all our colleagues said, that medical therapy, physical therapy is mandatory here. Maybe later on we can do some interventions in pain clinic.
Excellent. So
just to add one point, Othman, usually we explain to the patient that the surgery, the main aim of surgery is to improve the radicular pain, not the neck pain.
That's correct.
So that's the main indication for the surgical intervention, not the neck pain.
Yeah, that's good. That's maybe what Abdullah was referring to, is to manage the patient expectation preoperatively. That's excellent. Can we take another question by the nickname here? I think it says Dr. Bilal.
Assalamu alaikum. Thank you everybody for an excellent lectures and meeting. My question is to Dr. Osama, and anyone who can share the answer, please. My question is comparing the particulate versus the non-particulate steroid in cervical epidural steroid injection. What is the latest recommendation? And if it's like the latest is the non-particulate, why until now we saw and we observed some doctors, they inject still the particulate steroid?
Okay, thank you very much. It's a very good question. The answer is basically there is no difference can be seen between the two steroid agents. Although in our practice, we noticed that the particulate give us a better pain relief and prolonged pain relief compared to the non-particulate dexamethasone, basically. But there is, in the literature, there is nothing different. There is a survey done recently for a lot of pain clinics in North America, and you could see the variability between all pain or interventionist. Some they use the non-particulate, some they use the particulate. But at the end, the expert opinion says that if you are approaching the epidural space through the transforaminal approach, you're better off with non-particulate steroids. And if you are approaching it in the interlaminar approach, it's okay to use the particulate. And this is what we are doing in our clinic. Excellent. I hope I answered your question.
Excellent. So let's take the next question by Nathan. Nathan, briefly, please. Nathan, can you unmute your mic? Okay. Bilal, the next one, Riyadh. Riyadh, تفضل.
Assalamu alaikum. Can you hear me?
Yes.
Thank you all for your very nice presentation. Just I would like to add in our approach to the cervical radiculopathy in the sort of investigations, we should insist on the CT scan, the cervical CT scan, because okay, it's not maybe the case that the one you presented, but sometimes we got stuck with the problem of the OPLL. we had a feature of a herniated disc, but we discovered after that, it happened to me once with one patient. I got only an MRI, and we got stuck during the surgery with the ossification of the OPLL, so the posterior longitudinal ligament. So I would like to maybe to insist on the fact that in our investigation, in our approach to the cervical radiculopathy, do not jump directly to the MRI and go through the CT scan cervical so that we can plan our surgery if it is indicated after the conservative treatment. Thank you.
Thank you very much. Dr. AbdulKarim, you have any comment on that?
Yeah, I agree with that. Sometimes there is a small ossified, we can see it. We cannot see it by the MRI. So CT scan is best options. If you have plan, because you know the arthroplasty in general, it's that theoretical plan of it is to preserve the motion of the neck. So if you will do it, you have to do a flexion and extension X-ray just to make sure that how is it, and also CT scan to make sure regarding the bone quality, also regarding the facet of the side.
Excellent. So another question by maybe Marcel. Please go ahead. Can you unmute yourself?
Yes. Hello, yes. Good evening.
Good evening.
Yeah, I'm calling from Uganda, and thank you for all presenters for these great presentations. My question is about infiltration of steroid. At how many times? Like I give steroids, and the pain is still there. At how long can I decide to operate this patient, or I continue giving steroid?
If I understand you correctly, your question was how frequent you can inject before you, right?
Yes.
Okay. So thank you for the question. Happy to hear that Uganda is hearing us. We'll have Dr. Osama, please. When do you injection is permitted?
Not successful. Yeah. Sure. So basically, usually, if we are correct with the diagnosis and you give the right drug at the right time in the right place, usually you will have some effect. Now, if we don't have an effect where the procedure was done appropriately and with a good center, with a good interventionist, I would not to repeat it if it is not helpful to the patient. I would refer the patient to the surgery or do further investigation to see why it is not, maybe it is not the pain generator that we are actually approaching, maybe another pain generator. So definitely I will not repeat it if it is done appropriately, but I have to make sure it is done appropriately. In the past, especially in the United States, they do 3 injections and then they will reassess. I think the recent data suggests that once is enough. If you're not improved, don't repeat it again, because adding more steroid is not going to help the patient and might complicate the surgical approach in the future.
Okay, so another question by Raju. Bilal, can you unmute him? Okay. Go ahead, Raju. Raju, Fiva. I hope I'm pronouncing the name correctly. Excuse me if I'm not doing that. So, okay. Can we try Nathan one more time? Nathan, Thomas, try to unmute your mic and please ask your question. Can you help Bilal?
Actually, doctor is blocked from his side. I cannot unmute his mic.
Okay. Type. I think we can conclude here. We have one more. Brahim, I think he participated, but we can take his final comment, please.
Thank you for this. To give me the opportunity for a second question. My second question is about thoracic outlet syndrome, which is differential diagnosis, if you want to, or which is diagnosed that we can confirm after excluding other etiology for radiculopathy. So, in your experience, do you have practical management for this problem? Because when we do investigation for patients who have 50 years or 60 years, we will certainly find some cervical radiculopathy. So the question, if we will operate this patient, certainly we will know improve this patient. So in your experience, how can we manage this problem? Thank you.
Thank you very much. That's a very big question to conclude with. So we'll start with maybe 15 seconds for each speaker. Let's hear from Professor George, then Abdullah, Dr. Osama, then Dr. ABdulkarim, and by this we will conclude our session today.
Okay, so first, clearly try to understand from a differential diagnosis perspective, is any kind of red flags, any things that could cause those symptoms. If that's not the case, and in fact, I find that quite a lot of patients, even with neck pain, you find, altered neurodynamics in the upper extremity. So it's an area that I typically tend to work anyway. So, working, around the area myofascially, mobilizing the, different peripheral nerves in the upper extremity. So.
Okay. And do you differentially diagnose thoracic outlet syndrome?
From cervical radiculopathy?
Yeah.
Yes.
As a routine or?
Yeah, but so sometimes I find that the two things overlap, and I find it sometimes useful to actually work, even if there's a cervical radiculopathy, to work through the thoracic outlet, to work all the way down to the wrist. So actually helps desensitizing the structures anyway.
Excellent. Abdullah?
I'm with Professor George. From clinical diagnosis, also you can roll out the thoracic outlet syndrome. Is actually they are similar to the cervical radiculopathy. That's why, from my clinical view, the physical assessment it might differentiate the diagnosis. So the cluster refiner actually will help me to confirm the radiculopathy. However, the thoracic outlet syndrome, there is some examination, there is a good quality, a clinical quality to support, such as the root and the military test. So that's will roll out and differentiate between the two of them. But at the end, they will have the similar treatment in regards of physiotherapy approach.
Excellent. Dr. Osama?
So I'm sorry, I was answering some questions. I wasn't with you. If you can tell me what was the question.
The question was, do you think thoracic outlet syndrome is common with patients with radiculopathy, and if yes, do you usually rule it out if you receive a patient with radiculopathy before you treat the nerve roots?
Well, sure. Generally, it's not common, as most of the patients I've seen. So it's not a common complaint that you can see thoracic outlet syndrome, but definitely it is something that you have to keep in your differential diagnosis for sure. And if there is any sign or symptoms that lead to or let you think of thoracic outlet syndrome, you have to investigate and rule it out. That's for sure. But generally, the patient is usually, when they referred to our clinic, usually they are well investigated by either our colleague in neurology or neurosurgery or orthopedic before coming to our pain clinic. And we generally treat the pain component rather than any of the other symptoms component.
Excellent.
Thank you.
Okay, so the important point here is to do a good investigation to make sure that the source of the radiculopathy. So that's why in general we have to do an MRI, we have to do an EMG, and this is the indication for nerve conduction study, an EMG, just to make sure where is the source of pain. And if you are not happy or if you are not comfortable about the diagnosis, you can send him to the pain again for nerve block. So nerve block can diagnose also where is the source exactly. So I think the investigation is really important before doing any surgical intervention.
I would like to add one point is if the question was especially for the vascular pain, it is usually it comes with vascular signs and symptoms, and this is something that usually it could be clinically let's say clear, change in color, the thrombing pain, etc. As Dr. ABdulkarim mentioned, sometimes you do a nerve conduction study, MRI, that does not explain the radiculopathy. Then you think of other stuff. Clinical examination, like what mentioned by Abdullah and Prof. George, is something also good. Sometimes you do treatment / diagnosis by just blocking the nerve and see whether or not the patient is improving. And there is lots of gray areas between both sides, but I don't think that we should commonly suspect it, because it is much rarer than nerve root compression. And I'm sure that Dr. George was talking about the thoracic outlet as the structure other than the syndrome itself. So it was so fruitful. I was very happy to modulate a session with an excellent group of speakers, Professor George, Abdullah, Dr. Osama, Dr. ABdulkarim. Thank you very much for being with us. Thank you for participating with the Saudi Spine Society. Again, thank you for Dr. Faisal Gumbaz, for the head of the CME, our Continuous Education Committee, for giving us the opportunity. Hopefully we stay tuned and follow us on the social media and our website, and to look for the next scientific event, and hoping to see you inshallah again with another activity. Stay safe and see you soon. Thank you guys. Thank you very much.
Thank you.
Thank you.
Thank you so much. Bye.
Bye.